We looked at CDC recommendations for PrEP and PEP. We evaluated and managed drug-drug interactions. We looked at patients who experienced intolerable adverse effects and how to manage them. And we educated the patients on importance of lifestyle modifications. Now, when indicated, let's recommend immunization to patients living with HIV. Generally speaking, the immune response in people living with HIV is significantly lower. Even when the patients are receiving ART, the CD4 T lymphocyte remains significantly lower compared to people who do not have HIV. Even the B cell activation will be impacted by HIV, and this is most likely due to the persistent inflammation. Even in patients who have undetectable viral load, this inflammation persists. And in general, recommendations for vaccinations are similar in HIV patients, with the exceptions of a few contraindications in HIV patients, especially with CD4 count less than 200, because they will be severely immunocompromised, especially when it comes to live vaccines. In general, the data for vaccine effectiveness in HIV is very low, which has led to under-vaccination in people living with HIV. So we need to do a better job of vaccinating HIV patients. Let's take a look at recommendations for immunizations from ACIP. When it comes to people living with HIV, they are at increased risk for influenza severity, complications, hospitalization, and mortality. So therefore, the influenza vaccine is extremely important for these patients. So just like the general population, influenza vaccine is recommended for people living with HIV annually, and that's regardless of CD4 count. And that's for inactivated influenza vaccine. When it comes to live attenuated influenza vaccine, of course, we know that it is only recommended for ages 2 to 50 for the general population. When it comes to people living with HIV, it's actually contraindicated. So the live attenuated influenza vaccine is contraindicated regardless of CD4 count. Now, in October of 2021, ACIP met and made recommendations for the two new vaccines for pneumococcal conjugate vaccines, PCV15 and PCV20, which will replace the old PCV13. So now the recommendation is that for HIV patients, any PCV vaccine is recommended. So either the 15 or the 20. However, if someone gets the PCV15, it should be followed with a PPSV23. Whereas if the patient receives PCV20, then they no longer need to get PPSV23. This recommendation is for people living with HIV regardless of age. Now, for people who get PCV20, whether they need PPSV23 once they turn 65 is currently not clear. So we will have to wait to see the full document from ACIP recommendations probably early next year to see what they recommend. Currently, the recommendation is that everybody who turns 65 should receive a dose of PPSV23 regardless of anything they have previously received. And of course, if the patient has already received PCV13, for people who live with HIV, they do need to get 2 doses of PPSV23 5 years apart, and it has to be at least 8 weeks after the PCV13. Now, with hepatitis A and B, HIV is actually an indication to get these vaccines. In addition to HIV, in general, men having sex with men and people who inject drugs, as well as those who have cirrhosis and who are homeless. So if any of these apply to the patient, it's recommended to get the hepatitis A regardless of CD4 count. And of course, hepatitis B vaccination is extremely important in these patients because co-infection with HIV and hepatitis B virus actually increases the risk of mortality compared to having either infection as a mono infection. So, patients with HIV, Hep C, people who inject drug, cirrhosis, and men having sex with men, any of these are indications for getting the Hep B vaccine. Now for Tdap and or TD, just like the general population, it's recommended for these patients to get the booster every 10 years. they need 1 dose of Tdap, and then once, as long as the patient has received 1 dose of Tdap, every 10 years they need a booster of TD or Tdap. For meningitis, we have the meningococcal vaccines. We have 2 different formulations, one that has serotypes A, C, W, Y, and then we have a separate one that has serotype B, and there is one under development which will combine all 5 serotypes in the same vaccine. For people living with HIV specifically, serotypes A, C, W, Y are more likely to cause meningitis, so it is recommended for these patients to complete a 2-dose series 2 months apart, and then because these people will be living with HIV for life, they do need to get the booster every 5 years. Whereas Men B is not really recommended specifically for HIV. However, if the patients have other indications such as asplenia or complement deficiency, then they qualify to also get Men B. HPV recommendation is the same as general population for people living with HIV. For varicella, it's important to note that it is a live vaccine, so it is contraindicated if the CD4 is less than 200. So if the patient has severe immunodeficiency, it is contraindicated to give varicella vaccine. For people with CD4 greater than 200, it's a shared decision making. So, it's something that the clinicians should discuss with the patients to basically discuss, risk versus benefit to see if the patient is willing to take this. And then most recently, the ACIP also in October of 2021 made a recommendation to recommend zoster vaccine recombinant, which is basically Shingrix, regardless of CD4. This is not a live vaccine, so it would be safe to give to patients living with HIV. This concludes this presentation.